we'll start with the first of HSCT, basics of HSCT. So I'll be covering briefly on all aspects, and in future lectures, we'll touch upon the uh, details of each slide. So HSCT or hematopoietic stem cell transplant, commonly known as bone marrow transplant. So this is the most common modality currently for curative treatment of malignancies, marrow failures, or inborn error of immunity, and in certain cases of inborn error of metabolism. So it is the infusion of these cells to restore normal marrow functions in uh, these type of disorders. So it requires conditioning, infusion, and followed by immune reconstitution. So there are two types of HSCTs or types of hematopoietic stem cell transplant based on donor source. It is either autologous or allogenic. Autologous when we used patients' own donor cells, and allogenic when we use donor. So autologous is commonly used for most of the solid tumors in which we give high dose chemotherapy followed by stem cell rescue. Allogenic and then divided into either syngeneic when there is a twin donor transplant. Twin is actually a fully matched donor. Then there is related donor like sibling or parents, and unrelated donor. So allogenic also constitutes haploidentical hematopoietic stem cell transplant in which donor is not fully matched. It is more than 5 by 10 to 8 by 10. And 9 by 10 is considered as match donor. This is so rationale behind autologous stem cell transplant. It is used in chemosensitive malignancies. It involves high dose chemotherapy. So it can reduce the it can destroy the residual tumor cells and followed by rescue stem cells. So the advantage of this is graft versus, there is no risk of graft versus host disease or graft rejection because it is patient's own stem cells. Indications, commonest indication is multiple myeloma, then lymphoma, neuroblastomas. These are the FDA approved recommendation for autologous hematopoietic stem cell transplants. There are other disorders like Ewing sarcomas, medulloblastomas, in which it has shown benefit. Then one more indication is acute promyelocytic leukemia, in which autologous is as effective as allogeneic transplant. It is one of the leukemias in which center prefers to do autologous as compared to allogenic stem cell transplants. And there are certain experimental indications like autoimmune conditions like SLE, Sjogren syndrome, multiple sclerosis. Then allogenic stem cell transplant. So the rationale behind allogenic stem cell transplant is we use conditioning regimen to destroy the defective cells in the recipient. So these conditioning regimen usually are sensitive as if we are using malignant, if we are doing transplant for malignant conditions, then this should be chemosensitive, sensitive for these type of malignancy cells. Or if we are using for benign disorders, then the conditioning is used for destroying the patient's patient's marrow, so that the new stem cells which we will be infusing gets the place to regrow. And also in malignancies, the main reason behind allogenic stem cell allogenic stem cell transplant is graft versus leukemia effect. It means if we infuse graft source, if we infuse donor cells, we expect these cells to go and kill the tumor cells, which is actually the reason behind allogenic stem cell transplant. So there are multiple indications of allogenic hematopoietic stem cell transplants, all types of acute leukemias, certain chronic leukemias, then bone marrow failure syndromes, then thalassemias or sickle cell anemias, inborn error of immunity, SCITs, which includes SCITs, HLH, then inborn error of metabolism, and certain genetic disorders. So while we are doing allogenic stem cell transplants, the first step is to get donor. And To get donor, we need HLA typing, human leukocyte antigen typing. So initially, if we go 20 years back, only HLA A, B, and DRB1 were used to find donors. And as the science evolves, now we are using C along with DQB1, also DPB1. So we'll go in details in future lectures. What is the role of these HLA typings? And we do HLA typing to reduce the risk of rejection and graft versus host disease. So this is the typical high resolution HLA typing in which just yeah. So HLA is prefix. The A, B, C is what is the gene. So there are MHC complex, major histocompatibility complex, in which there are different genes classes. Class 1 is ABC, class 2 is DQ, DP, DQ, DR, DP, and there are other complements which are also helps in which are also included in HLA typing. So A is gene, then the first digit is allele group, then second is actually antigen group, third is synonymous DNA substitution within the coding region, and fourth is within the non-coding region. So this is a classical high resolution HLA typing. So ideal is to get full match donor. If that is not possible, then something called 9/10, 9.5 donors, which this term is used by certain centers, in which the allele group is same but antigen group is different. So it is 9.5. Now moving to stem cell sources. So there are 3 types of stem cell sources: bone marrow, peripheral blood, and cord blood. So in India, most of the centers are using bone marrow and peripheral blood because the non-availability of public cord blood registry, cord blood transplants are very rarely used in India. So there are certain advantages and disadvantages of these sources. Bone marrow has lesser number of CD3 cells, so less chances of GVHD, less chance, lesser number of CD3 cells or T cells, so less GVHD. Also, bone marrow has disadvantage in terms of slower engraftment. So around 3 to 4 weeks required for neutrophils to engraft in bone marrow sources. Peripheral blood has higher number of CD3 cells, so there is high chances of both acute and chronic GVHD with peripheral blood source, but it has advantage of faster recovery. So we get around 2 to 3 weeks of neutrophil recovery after infusion. So by default, most of the centers are using bone marrow graft for benign disorders and peripheral blood graft for malignant disorders. Now moving to selection of donors. So it is preferable to get full match donor 10/10, high resolution full match donor. If that is not available, then 9/10 matched donor. If it is not available, then unrelated donor. And if that is not available, then haploidentical. So there are different steps in choosing these haploidentical donors for unmanipulated as well as manipulated stem cell transplant. So the first step is to get donor-specific antibodies. If donor-specific antibodies are not there, then these are the other steps like ABO compatibility, then donor age, younger donor is preferred, female donor is not preferred for male recipient, and other like NEMA mismatch is preferred over NEPA mismatch, then KIR ligand, which we will be discussed in subsequent lectures. If DSA is positive, then we should look for the titers MF5 If it is, some centers use 2000, some centers using 3000, and some centers are using 5000 as cutoff for desensitization. If it is more than that, then probably desensitization will not help.
So,
So
Amit,
now
I just
moving,
wanted to know one question from your previous slide. Other than
yes,
that HLA typing, do we check any cell surface markers also like CD34, CD3 of course will be used, but any hematopoietic cell surface markers also do we check before transplant?
no, we do not check. There
Okay.
are certain uh, transplants like ALCL in which we see CD3. If CD3 is positive in patients, if CD3 is positive in the histopathology report, then we prefer
Mm-hmm.
allogeneic transplant as compared to autologous transplant, where because there is high risk of relapse in that patient. Yeah.
Okay.
Apart from that, for HLA, only HLA typing is good enough in
Okay.
selection.
Okay.
Now moving to the steps in hematopoietic stem cell transplants. After once we select the donors and donor is fit, recipient is fit, first step is mobilization. So in autologous stem cell transplant, uh, patient or recipient is mobilized for stem cell transplant once the bone marrow is in remission. So mobilization, there are different strategies in mobilization. Like we can use GCSF alone or GCSF with Plerixafor or chemomobilization. So GCSF or GCSF plus minus Plerixafor. Plerixafor is actually a CXCR4 antagonist, which helps in detaching these stem cells, and thereby help in moving into the peripheral blood. So uh, there are indications of using Plerixafor in situations. The cutoff of we usually do absolute peripheral blood CD34 count on day 4. If it is less than 10, then there is indication of using Plerixafor. If it is between 10 to 20, this is gray zone. If it is more than 20, Plerixafor is actually not required. And chemomobilization is also feasible in certain types of autologous stem cell transplants like lymphoma, or in which this GCSF Plerixafor mobilization fails. So most common is cyclophosphamide 1 gram per meter square for 2 days, and once we give around day 10, day 11, we start checking CD34. If it is growing, if it is improving, if it is more than 10, we usually start harvesting of these patients. So once we get adequate harvest, so adequate harvest in books, it is usually mentioned CD34 more than 2 is good enough. But most of the center prefers 3.5 as the optimal CD34, because lower the CD34, there is chances of prolonged neutropenia leading to in sepsis and all these complications. So at least 3.5 CD34 is optimal.
Yeah, that's what I was asking. The CD marker, the CD marker, CD34 and all. Do we
No, no.
check
So,
it?
so we check not for a selection of donor.
Mm-hmm.
We checked for during means before harvesting.
To check the number of how many cells are expressing CD34.
No, so we sent peripheral blood to
Uh-huh.
check absolute CD34 count. It is mainly
Oh,
used for autologous transplant, or when the donor has received significant amount of chemotherapy or radiotherapy, or certain specific chemotherapies like ifosfamide or bendamustine or lenalidomide. These chemotherapies or radiotherapies reduces the stem cell reserves in these patients. So chances
okay.
of adequate mobilization in these patients is poor. So to counter these to improve the mobilization in these poor mobilizer, now we have Plerixafor, so which helps in getting adequate stem cell count in 1 or 2 harvests.
Okay, okay, understand. Oh.
So this is what is the mobilization. Then we start conditioning. So around 2 to 3 weeks, peripheral blood stem cell harvest. Engraftment happens around 2 to 3 weeks, then 3 to 4 weeks for bone marrow graft, and 4 to 6 weeks for umbilical cord graft. So this is what we have discussed. This is the mobilization protocol. There are newer studies in which they have used PEG-GCSF also, peg-filgrastim, and they mobilized at day 4, day 5, and they find adequate stem cells even after PEG-GCSF. Now, pegylated filgrastim. Okay. So now moving to conditioning regimen. So conditioning regimen is divided into 3 types: myeloablative conditioning regimen, reduced intensity, and non-myeloablative. Myeloablative ones are those once we have given, there is no chance of stem cell, no chance of recovery. Reduced intensity is when chances of count recovery is there by 3 months, and non-myeloablative, which we commonly used for AML or ALL ALL chemotherapy regimens like FLAG-IDA or CLAG. So there are every drug has its dose after beyond which they are defined as myeloablative. Like busulfan, IV busulfan more than 8 mg per kg is myeloablative dose. Oral is more than 9.6 mg per kg is myeloablative dose. In similar way, TBI more than 5 gray single fraction is myeloablative. Fractionated TBI more than 8 gray is myeloablative. So myeloablative conditioning regimen has its own complications, like main complication is organ toxicity or even gonadotoxicity. To overcome these challenges, there is now a new term called reduced toxicity conditioning regimen. So the most common one which replaces busulfan is triosulfan. Triosulfan is less gonadotoxic, less hepatotoxic, and less with triosulfan, the complications are less. So in this graph, every conditioning regimen has 2 parts. One is immunosuppression, one is myelosuppression. So immunosuppression is mainly used so that the graft which we will be infusing gets engrafted. Myelosuppression is to get the space for the newer stem cells. So the commonest first conditioning regimen which was tried was TBI 12 gray. Then they introduced Cy-TBI, then Bucy. And as we move along, the newer drugs like fludarabine has completely replaced cyclophosphamide as immunosuppressive agent. So most of the conditioning regimen are now using fludarabine as immunosuppressive agent. Along with that, either busulfan or triosulfan. One more drug is thiotepa, which has good CNS penetration. So the commonest conditioning regimen for what we called those who have hypercellular marrow is either Bucy or fludarabine with triosulfan with thiotepa in most of the benign disorders. There are other terms like ATG or alemtuzumab. These are serotherapies which we commonly used, and almost in every patient we use these of benign disorders like thalassemia, sickle cell disorders, in which we do not want any kind of GVHD. So ATG and alemtuzumab are used as a serotherapy in these patients. Also, TBI 200 gray is immunosuppressing agent. And TBI more than TBI 12 gray is actually myeloablative. So those disorders in which the risk of rejection is high with haplotransplant, we use 2 gray TBI as immunosuppressive agent. Moving on to GVHD prophylaxis. CNI and short course methotrexate is the commonest and time-tested GVHD prophylaxis in match sibling donor transplant or match-related donor transplant, and even in unrelated full match donor transplant. So if a patient has if patient cannot tolerate methotrexate, we can substitute with MMF. CNI can be either cyclosporin or tacrolimus based on the tolerance of the patient. The second is post-transplant cyclophosphamide, which is actually the one of T-cell replete hematopoietic stem cell transplant. There are other strategies like ex vivo T-cell depletion strategies, which are actually based on the Miltenyi platform, in which they remove the CD3 cells. Initially, they started with positive selection, like selection of CD34 stem cells. Even after that, they noticed GVHD. Then they started negative selection of CD3 cells. Then they noticed that there is chances of viral infections with the CD3 negative selections. Then they did CD45 RA depletion and CD45 RA depletion while keeping CD45 RO cells. RO cells are memory cells, RA cells are naive cells. So naive cells causes GVHD, memory cells helps in fighting viral infection. So currently what we are using is CD3 depletion along with CD45 RA depletion and CD45 RO add back if they develop any infections. So this is the evolution of conditioning regimen, GVHD prophylaxis and transplant over the years. We have done the reinfusions. Once we are getting adequate harvest, adequate stem cell, and we have conditioned the patient, we infuse the cells on day 0 and expect engraftment. So engraftment are of two types: neutrophil engraftment and platelet engraftment. This is around 2 to 3 weeks for peripheral blood. So during these 2 to 3 weeks, chances of getting infection, chances of bleeding is there. So for which supportive care is required. So neutrophil engraftment is defined as when patient has achieved more than 500 WBCs, 500 neutrophils for consecutive 3 days, and first day is defined as the date of engraftment. Platelet engraftment is when the patient has achieved more than 20,000 platelets for consecutive 7 days and not required platelet transfusion in last 3 days. So this is what is platelet engraftment. For engraftment, GCSF can be used based on the type of transplant, that intricacies which we will be discussing later. Now moving on to complications. So complications are divided into 3 types. Early complications. Early complications is divided into pre-engraftment, post-engraftment, and late complications. So pre-engraftment, since neutrophils are not there, chances of bacterial and fungal infections are very high. Other complications like complications secondary to chemotherapy, mucositis, veno-occlusive disease is common. Once the patient has engrafted, complications are infective complications includes viral infections. So viral infections, because of the conditioning regimen and serotherapy, these patients do not have adequate T cells to fight viral infections. Even if they have T cells, probably the functions are not adequate in these patients to fight the viral infections. So viral infections are can be one of the complications after engraftment. Then fungal infections, because to fight fungal infections, T cells are required. These are the complications. So once the patient adequate CD3, CD4, CD8 cells, adequate, they have more than 200 CD4 cells, which actually immune reconstitution. So once the patient has 200,
Shubhangi sister, please mute yourself. Whoever is not mute apart from Dr. Amit, please mute.
So immune reconstitution. Immune reconstitution actually depends on the type of conditioning regimen and the usage of serotherapy or post-transplant cyclophosphamide. So first cell to engraft is first cell to reconstitute is neutrophils, followed by NK cells, followed by B cells, and followed by T cells. Based on the functionalities of these cells, the chances of infections in these patients are there. Now, moving on, graft versus host disease and graft rejection. So, graft versus host disease is defined as when the graft which we have infused attacks the host cells or recipients and thereby causing the complications in these patients. So, it is divided into two types, acute and chronic. By older definitions, if it is occurring within 100 days, it is called acute GVHD. If it is beyond 100 days, it is called chronic GVHD. There is some overlapping GVHD also, which we will be discussing later. So acute GVHD commonly involves skin, gut, and liver, and it is divided into stage and grades based on the classification. So stage and treatment of which is first line treatment is steroids. Chronic GVHD, when it happens beyond 100 days, the commonest organ involved is skin. Chronic GVHD can involve any organ from head.
If he's not going home, रूंगता जी है क्या? नहीं वो कब की फ्लाइट है? रिटर्न फ्लाइट कब?
Vijay, please.
Sorry.
Vijay, you are unmuted. Yeah.
Okay. So chronic GVHD can involve any organ, any site of the body. Management is first line is steroid in both the scenarios. Then there are many agents. Nowadays, the second line agent is ruxolitinib. We will be discussing all these aspects in detail in subsequent lectures. So infective complications, which we have already discussed in pre-engraftment, bacterial and fungal infections are common. Early post-engraftment, some of the viral infections. Commonest is CMV infections. In haploidentical transplant, almost all patients develop CMV infection. Then late complications, encapsulated bacteria because of the B cells have not reconstituted and exposes these patients to get encapsulated bacterial infections or varicella. So to prevent all these complications, some or the other antimicrobial prophylaxis, we will be continuing for the certain designated period of time based on the immune reconstitution of these patients. So there are recent advances in hematopoietic stem cell transplants like haploidentical transplants. Now, if matched sibling donor is not available, most of the centers are going for haploidentical transplants, not waiting for unrelated donor because unrelated donor takes time. And haploidentical transplant with post-transplant cyclophosphamide has as good outcome as match unrelated donor transplant with low cost. Then as we know that CAR T therapy is used to get ALL or non-Hodgkin lymphoma patients as a bridge or consolidation. Thereby, we can do transplant to achieve better outcomes in these patients. Then TCR alpha beta CD45 RA depletion, which is now the commonest modality in T cell deplete transplants, but the cost is constant because this requires Miltenyi platform and the cost of which is around 10 to 12 lakhs. And personalized conditioning regimen. Now the word is moving towards triosulfan because of less gonadotoxicity, less hepatotoxicity. But triosulfan has some disadvantages also, like if we do bone marrow with triosulfan, bone marrow with triosulfan, then chances of mixed chimerism is there in benign conditions. Future of HSCT is like gene edited hematopoietic stem cell transplants like we do in thalassemia and sickle cell anemia, in which we use myeloablative conditioning regimen for the infusion of these gene edited hematopoietic stem cells. Then immune monitoring for risk stratification of these patients. So this is based on the immune reconstitution. We risk stratify these patients into low and intermediate and high risk of getting infections, and the prophylaxis is based on that. This is the newer concept, microbiome modulation, in which those patients who develop gut GVHD or Clostridium difficile infections, we can actually use healthy donor stools for
FMT, FMT,
yeah, FMT, fecal
fecal
microbiome.
metal test. Yes.
So which is the modality of actually the recommended treatment for Clostridium difficile, and studies is going on in treating patients with gut GVHD also, and the cellular therapies. Okay, thank you.